Good morning and welcome, good afternoon, and welcome to the first event in the 2022 Healthy Working Live seminar series, focusing on the Compare project. So there are 6 free seminars altogether over the next couple of months, and it's fantastic to have you here. Whether you're joining us live or watching the replay, welcome. We acknowledge the sacred land of the Bunurong people on which I am based and which we are based, and pay our respects to the thousands of years of wisdom and knowledge found with the Indigenous owners of the land. Wamundjika, kia ora, and welcome. I'm Dr. Elizabeth Pritchard, a research fellow from the Healthy Working Lives research group at Monash University, and I will be your MC today. So in today's seminar, we have 2 presenters. The first is Dr. Michael Di Donato, Research Fellow from the Healthy Working Lives Research Group. And we also have joining us today, orthopaedic surgeon, Professor Ian Harris, presenting on the topic of opioids, imaging and surgery in workers with low back pain. And it's identified as the unholy trinity. So there will be a short Q&A at the end of the session. However, throughout the seminar, you can submit your questions on the way through with the Ask a Question button, which you'll find just below the screen that you're watching the seminar on. So scroll down, feel free to ask questions all the way through, and we have Q&A at the end as well. We may also answer some questions along the way. We've got some people in the background. So without further ado, I'm going to hand over to Michael, and we'll be back really shortly.
Afternoon, everyone. I'm Michael Di Donato. Thank you for the introduction there, Elizabeth. This afternoon, I have a bit of a chat about opioids and imaging for low back pain, and then Professor Harris will join us to talk about surgery for low back pain. So low back pain, a bit of context first, leading cause of disability worldwide, responsible for about 60 million years lived with disability. It's the leading cause of non-fatal disease burden in Australia, and the second leading cause of total burden behind coronary heart disease, as you can see from this table from the Institute of Health and Welfare. So although episodes of low back pain are usually self-limiting and usually have a positive prognosis, it's often hard to attribute a specific cause or damage to a specific anatomical structure, and mostly they can cause, in many cases, can cause a fair bit of disability. In many cases, the pain can cause, like I said, a great deal of disability, and if the back pain is work-related, somebody might lodge a workers' compensation claim for time lost or medical expenses. So in Australia, between 2010 and 2015, there were over 56,000 claims for low back pain longer than 2 weeks. And those with low back pain claims were off for a median of 9 weeks. And that's about the same as a claim for a limb fracture. So it can be quite severe. So diagnostic imaging. Well, diagnostic imaging is something that we commonly hear about for back pain, but it's not necessarily the best thing. So guidelines over the last 30 years, including those for compensable low back pain, consistently recommend against imaging for a new episode of low back pain, unless clinical assessment suggests the possibility of a serious pathology, such as malignancy, infection, or fracture. Abnormalities are common in people who are asymptomatic, abnormalities on imaging, I should say. And this increases with age. So their presence on imaging results is not really helpful on guiding diagnosis or management in individual patients. And early imaging can lead to further unnecessary tests and treatments that can cause more harm than good. But we do know that 1 in 4 people presenting to primary care and 1 in 3 presenting to emergency care are being referred to imaging, and the rates of complex imaging are going up over time. And also that using imaging in compensated workers can lead to more time off work. So as part of the Compare project, we conducted a study to determine the prevalence and impact of diagnostic imaging in compensated Australian workers with low back pain. So this study included claims from Victoria, Queensland, South Australia and Western Australia from 2010 to 2015, longer than 2 weeks duration. So in a sample of 30,530 workers with claims for low back pain lasting 2 or more weeks, about a third received spinal imaging once, and 20% received spinal imaging multiple times, so just more than once. And the remaining 49% did not receive spinal imaging. So you can see that spinal imaging is relatively common in people with claims for low back pain, about half of them. Male workers and workers from Victoria had significantly higher odds of multiple imaging, and socioeconomically advantaged workers and workers from remote regions had significantly lower odds of multiple imaging. The most common imaging, unsurprisingly, was for MRI, and about a third of the cohort received almost 15,000 MRIs during the study period. The workers who received no spinal imaging during their claim had the lowest median wage replacement duration of about 6 weeks, but wage replacement duration was significantly longer among those who received both single and multiple spinal imaging tests during the claim period of 2 years following their injury. The prevalence of imaging is higher in compensated workers than in the community, although we should note that these are quite serious claims with a minimum claim duration of 2 weeks. The prevalence of imaging is higher than what would be expected, though, if everyone was receiving guideline adherent care. We think this might be driven by a number of reasons, potentially by healthcare providers. Healthcare providers might request imaging due to beliefs or routine practice, to provide reassurance to the workers or to meet the workers' perception of the workers' needs, or out of fear of litigation. But workers' compensation is also cause-based, and a definitive diagnosis may be sought, which is pretty challenging with back pain. We also found that increased wage replacement, as you just saw, wage replacement duration, time off work, was associated with imaging, and that's consistent with other findings. Why might this be? Well, we theorise that the use of imaging may lead the worker, the healthcare provider, or even the workers' comp system to erroneously attribute the source of back pain to some sort of structural damage. One of these stakeholders may then expect a complete recovery, which may in turn trigger the use of additional or more invasive healthcare, such as injection or surgery. And ultimately, this would lead to a longer wage replacement duration. So what about opioids? Another common thing that we hear about associated with low back pain. Well, guidelines recommend the prescription of opioids for low back pain really as a last resort. They should really be judiciously used. If they are prescribed, they should be used in a low dose for a short duration, as there is limited evidence that opioids provide clinically important benefits to pain or disability. And a recent systematic review of 20 trials, of which 13 evaluated the short-term benefits of opioid use, over half of the participants withdrew due to either adverse effects or a lack of efficacy. And there are well-known adverse effects as well. So really, opioids should only be used after conservative treatment or a trial of NSAIDs, such as ibuprofen. So in this study, we sought to characterise the patterns of opioid dispensing and the association between those patterns and time off work. We've included workers from Victoria and South Australia from 2010 to 2013 with time loss claims. So a slightly smaller sample in this case. But we used a trajectory model to cluster workers by how many opioids they were dispensed every 90 days for 2.5 years from their date of low back pain onset. So about a third of these workers received opioids during that time. That's pretty consistent with what we know internationally. And of those who did receive opioids, most of those individuals received them at a low dose for a short duration with a median of 3 total opioids in 2.5 years, 3 dispensed opioid dispensers, if you will. But there were a small proportion of people, as you can see, 7.5% of those individuals who had opioids for a very long time at a very high volume, with a total of 72 instances of opioids being dispensed to them after 2.5 years. So quite a lot of opioids. There weren't many differences in demographic factors, but there were some slight interjurisdictional differences. South Australian workers had greater odds of being in the short-term group, and Victorian workers greater odds of being in the longer-term group. And we found that opioid use was associated with a longer wage replacement duration. So those who did not receive opioids had a median duration of 7 weeks, while the median duration jumped up to 30 weeks for the short-term, people who used opioids short-term or received opioids short-term, I should say, and around 126 weeks, so pretty close to the upper limit of wage replacement duration in both jurisdictions and the other 2 groups as well. And you can see that there in the survival curves, that those 2 higher groups tend to tail off at around 130 weeks, which is the upper limit for Victoria and South Australia's time off work. So receiving opioids was associated with significantly longer periods of wage replacement. and the proportion of workers with accepted time loss claims who received opioids was pretty similar to what's been found in North American studies. This is consistent, like I said, with previous studies, in that a small portion of workers will receive a very large amount of opioids for quite a long time. One of the limitations was we didn't really have information on dose, how much they were receiving. So you might have noticed that the moderate and high volume groups were very similar in their wage replacement duration, and that just may be to do with the strength of the opioids that those people were receiving. In the future, and in the context of other studies, it would be good to look at how policy interventions might help stem some of this long-term opioid use. And several studies have done this in the past, measured this in the past elsewhere. We just haven't really measured it in Australia to much extent in workers' compensation. But there have been a number of changes implemented that we could measure. For example, in 2018, codeine went from being over-the-counter to a prescription medicine in so-called up-scheduling of the medicine. So in the future, it would be good to measure the effect of that on medicines distributed to compensated workers. But that kind of covers opioids and imaging. Our next presenter is Professor Ian Harris, who is an orthopaedic surgeon and researcher at the University of New South Wales. And I will hand over to him very much in a moment. We'll hand over in a moment.
All right. So thanks for having me. I've got only a handful of slides here, but I'm going to talk to you about an area of interest of mine, which is the effect of workers' comp on outcome after surgery. This is what got me into academia in the first place, this topic. It used to puzzle me how these patients did so much worse. And so I started documenting this. And in particular, spine surgery has been an area of interest of mine because of I think the overuse of surgery. So I'm going to show you some of the research that we've done in our unit. So starting with this one, this is a study we published recently, I think it was just in the last year or so, in the Pain Journal. And we looked at the evidence, the randomized controlled trial evidence for surgery for musculoskeletal pain in common surgeries. So what we did with this study, we looked at all surgical trials on common surgery. So this is things like, again, knee arthroscopy, knee replacement, hip replacement, shoulder arthroscopy, rotator cuff repair, spine decompression, spine fusion, etc. And we wanted to find out, we've looked at all the RCTs, so we've got thousands of RCTs, and we wanted to find what proportion of all the RCTs we could find compared doing the procedure to not doing the procedure, because that's not very common. And then once we got those RCTs, what's the proportion of those RCTs that were favourable to surgery? And we defined favourable as having a statistically significant improvement and a clinically important difference. And I was also interested to see how many of these studies were blinded, because that's coming a little bit more popular now to do these blinded surgical studies or placebo surgical studies. So that was the thing. And we looked at lots of different operations, but of course for this talk, I'm just going to focus with the spine outcomes. And so these are some of the things we looked at, and we're just going to focus on the disc replacement and things like that. So overall, we had over 12,000 trials to sift through. But for lumbar fusion for back pain, for instance, we found 905 studies. I think a few of them were duplications, got down to 912. There was a fair few for disc replacement and a fair few for laminectomy for lumbar spine stenosis, which is another common condition. But we'll concentrate on spine fusion for back pain because I think that's the big problem area. So we found over 1,000 trials in the spine area and nearly 1,000 for spine fusion alone. But very few satisfied the criteria of comparing doing the operation to not doing the operation. So I'll take you through this table. So this tells us that we found that there were 69 randomized controlled trials on the topic of total disc replacement, anything to do with total disc replacement. And only one of those 69 studies compared doing a total disc replacement to not doing a total disc replacement. Physio, whatever the comparator is, it just had to be not a total disc replacement. And in spine fusion for low back pain, out of 900 studies, 9. So overall, it was less than 1% of all the RCTs done out there on these common procedures compared doing it to not doing it. Of those 9, 2 were favourable. None of the studies were blinded. None of these studies were favourable. None of these studies were favourable to surgery. So overall, we found it was actually less than 1% of all RCTs compared doing the procedure to not doing the procedure. 15% of those studies were favourable to surgery. So 85% of the studies concluded that surgery was no better than not doing the surgery. Now, this is interesting. 9% of those studies were blinded. Most of those are in shoulder, some in knee, but none of the studies where the patients were blinded, the patients didn't know whether they had the real surgery or the placebo surgery. None of those studies were favourable to surgery. We also reviewed lumbar spine fusion in another paper, Internal Medicine Journal, again, just in the last few years. This was sort of a review of reviews, and where there were no reviews, we just looked at RCTs, and we looked at all these different conditions for which a spine fusion might be done. But if we focus on degenerative conditions, which is really this is the workers' comp setting, we found 33 systematic reviews of 4 trials. That's really typical. When you find many more reviews of trials, then you know you've got a problem. So it's a question that everybody wants answered, but nobody's answering it. That's what it tells me. And it found no significant advantage of surgery over cognitive behavioural therapy or exercises, and there was no advantages for doing a fusion when you did a revision decompression. That was another indication that people often use. So there's not much evidence for this operation in the first place. Let's look at what the results are in workers' comp. This is a study we published again recently. This was just published last year. And what we did is we got a whole lot of data, all of the data from CIRA in New South Wales for workers' comp spine surgery, and over a 9-year period. So we looked at, I think it was actually an 8-year period because it was mid-2010 to mid-2018 from memory. And we looked at the rates, the costs, and the return of work. And certainly we found the rates increased over time. I haven't reported that here, but we had about 10,000 claims to play with here. So we could do a lot of stats on it. Now, in spine surgery, we often divide things into decompression alone or fusion with or without decompression. And most of the time, decompression is by far the most common procedure done in normal spine practice. In workers' comp, though, it's 40% spine fusion, which is fairly high. Now, looking at the results, we focused on looking at the results we had. So we didn't have patient-reported outcomes for this. What we did have was things like return to work. So we took a 24-month overview. We also did results for 12 months, but we thought really people should be back to work by 24 months. So if the reason they're having the operation is to get them back to work, is it working? And so we found for spine fusion, it's much worse than decompression, but we found 19% for spine fusion, 39% for decompression were able to return to full capacity. A smaller group reduced capacity, but most were not working. This is 2 years after the surgery. We also looked at revision surgery. This is broken into cervical and lumbar by far the most common. The numbers here were small. The numbers here were much larger. And on average, there was a 19% incidence of having another spinal operation, not necessarily the same level, but another spinal operation within 24 months of the initial surgery. So that's very high. You wouldn't expect to have 1 in 5 knee replacement patients having another operation on their knee within 2 years. That shouldn't happen. It normally means that something's not right or something wasn't addressed properly in the first place. So this is very high, but it's actually consistent. There's another study from the US looking at a workers' comp population showing 20% reoperation rates within 2 years. So it's not out of the ordinary. So this study that we published last year was actually an attempt to repeat a previous study we did about 10 years ago. And this looked at a cohort of around 450, again, New South Wales workers' comp spine surgery patients. And we went to each of the insurers in those days and had to sort of pull out all the records. Some of them were electronic, some of them weren't. We had to go through files. And we looked at the return to pre-injury duties. So this is not just full capacity. This is the same job they were doing before. That was our definition. And we found that after spine fusion, lumbar fusion, only 3% of people were doing the job they were doing before at 24 months. We also looked at ongoing treatment, and the main ongoing treatments were whether they were getting prescriptions for major opioids or whether they were attending physiotherapy. And we found that at 24 months after the fusion, nearly 90% of people were either still taking major opioids or getting ongoing physiotherapy 2 years after the procedure that was meant to relieve their symptoms. The effect of workers' comp on outcomes after surgery in general has been studied by others. And I like to think that we started this back in 2005. We published in JAMA this meta-analysis, and this was part of my doctoral thesis at the time on this topic. And we looked at lots of different operations, but I'm just highlighting the spine ones here. So this is a review of all studies, not just randomized trials, that looked at the compensation status of patients and the effect of that on the outcome. And what we concluded was that the odds ratio of a bad outcome was more than 4 times higher in compensated patients compared to non-compensated patients. And the other thing I said, how it's more common in the private sector. This is another study we did, looked at trends of spine fusion, and we found that in the public sector, the rates of spine fusion are low and not increasing. They're high and increasing in the private sector. And this is interesting because this coincides with the time that MRI scans became rebatable and widespread. So that's the talk. So in summary, I guess the evidence for a lot of these procedures is lacking. I needed to say that first. The evidence that we have is not supportive. So we know that the outcomes aren't very good, and yet the outcomes in workers' comp are even worse. So this is an operation which I think is questionable in this setting. So I'll stop there, thanks. And I think I'm going to hand back now. We're going to go to questions.
Well, great. Thanks, everyone. We're back in discussion now, and thanks for joining us, Ian. I was just thinking about those numbers, you know, like very little evidence there for spinal surgery for back pain or for spinal surgery in general. Is there anything that you think drives these numbers in the workers' comp population, given we're still, you know, they're still performing these procedures despite the evidence?
Yes, what's driving them is a belief in effectiveness, and the fact that outside the workers' compensation population, a lot of people will say they get better because a lot of people say a lot of people get better. They just don't necessarily get better because of the surgery. And that knowledge is being applied in the workers' comp situation, even though they're very unlikely to get better. I think there's financial drivers as well, because the reimbursement is very high. So I didn't put the numbers up there, but the average cost to the system is tens of thousands of like $70,000 or $80,000 for a spine fusion. The surgeon fees varied between sort of 12,000 to 30-something thousand for a single procedure. So it's a very highly remunerated procedure. So if there's some question about whether it's needed or not, the patient's willing to give it a go. You know, you've got some evidence from colleagues, etc. You don't need a whole lot of evidence to push yourself to do things. I mean, we know from the other procedures, knee arthroscopy and things like that, just a mere thought that it might work is enough to do the procedure. you throw a $20,000 fee on top of that, and let's do it. I mean, I used to do this surgery. I don't do spine surgery anymore, but I was doing spine surgery for a fair while when I started practice, and I was doing spine fusions on workers' comp patients, and it was very well rewarded, and I did it because I thought it worked. And it was only later, when I got into academia and I started looking at the evidence, that I found out that the evidence for this is absolutely terrible, and we probably shouldn't be doing it.
Yeah. And I mean, it's such a massive cost. I wonder if it's kind of it's a massive cost, but it's not a cost to the worker, I suppose. And look, they're not experts in the evidence of back pain. So if they've been told that it works, I suppose it's an opportunity to do it.
Yeah, it's a hidden cost. There's another massive incentive, of course, is this perverse whole person impairment system that we have, which I think is completely upside down for spine surgery. So what we have, if you have somebody with back pain, according to the AMA guides for whole person impairment that you're all familiar with, if somebody has back pain and just degenerative changes in their spine or whatever, they get 0% whole person impairment, because there's no whole person impairment for pain alone. So they get no payout. If they have surgery to address that pain, so if they have the treatment for that pain, as soon as they've had a spine fusion, they automatically qualify for, I think it's 23 to 25%, something like that, 22 to 24% whole person impairment. So they've gone from receiving nothing to receiving a huge payout. So the lawyers want them to be fused. They want them to have a spine fusion, because does that make any sense to you? Like if you had a broken leg, or a leg that had healed crooked, you'd be entitled to some compensation. If you had the surgery to correct that and it was no longer crooked, you wouldn't get any compensation. So that makes sense to me. You wouldn't have any impairment once you had the treatment. But it's the opposite in spine surgery. If you have back pain, you have 0% impairment. If you have a spine fusion, you automatically, even if you feel great, have 22% whole person impairment. That's a system that's got to stop. It just has to stop. It's perverse. It makes no logical sense at all. And yet we seem to be wedded to it. And there's no appetite to reduce it.
Kind of what body is deciding that what degree of impairment is for
this is the American AMA guides to the impairment of it could just call the AMA guides, but it's what's adopted in Australia. It's what we use, because we couldn't be bothered making our own, and we adapt them a little bit. We have made changes to them, and they're in New South Wales anyway. I know it's state by state. In New South Wales, there's a little handbook that goes with that big American AMA guides, which says, oh no, we don't like this one, and we change this one, and this one should read this, which is often common sense, sensible changes. But nobody's made the change that I think needs to be made, which is if you have the treatment, you don't have the impairment anymore. It doesn't work.
Yeah, I agree. It's astonishing that once you've been treated for the condition, you are more impaired than when you hadn't been treated for the condition by that treatment modality, I suppose.
It's not 1 or 2%; it's 22%.
It's from 0 to 22%, which entitles a great deal of financial compensation.
Everything in the system incentivizes surgery.
Yeah.
The financing of the system incentivizes procedures, because procedures are things that are paid. Private hospitals love it. So private hospitals make their money on people under workers' comp getting fused. That's how they make money. They want more to be fused. I tried to do a study on this once, and I wanted to interview some people, and I was talking to the CEO of a private hospital, and I wanted to look at why people were getting so many fusions in the private hospitals and they weren't getting them in the public. And her attitude was, oh yes, we'd love to contribute to that, because I think it's fantastic how the private hospitals are filling in the need that the public hospitals are not addressing. And we're providing this great cure to people that aren't able to get it in the public sector. So that's their belief. But yeah, the whole system incentivizes procedures. The lawyers want it, the patients want it. It ups their disability. It proves that they've got an injury. The hospitals want it now.
It's interesting as well that you pointed out that the kind of uptick in spinal surgery in private hospitals coincided with rebate for MRI. I mean, in our study, we saw half of the population, half of the sample, had spinal imaging at some point.
Yeah, it's terrible. I mean, and I apologise. I was giving another lecture somewhere else, and I had to come in late. I only caught the end of yours, so I apologise if I trod on your toes there a little bit. But it's the imaging is a problem. There's been studies shown that if you take patients who present to a GP with back pain, you randomise one group to getting an X-ray and the other group to getting an MRI, and then you let nature take its course. Whatever the doctor does, they do. And you look at those patients a year later, you'll find no difference in the reported back pain in those two groups, whether they had an X-ray or an MRI. The only difference between those two groups is the group that had the MRI will be significantly more likely to have had an operation in the meantime.
Yeah.
It won't be any better, but they would have had surgery because the MRI will find something. You, me, anyone in the audience, if you have an MRI, it will find abnormality. I've been in practice now for 30 years. I've never seen an MRI report that says there's nothing wrong here. It just doesn't exist. Somebody please show me that report. This spine is normal, full stop. It doesn't happen. It doesn't happen in anyone aged over sort of 30 anyway.
Yeah. I wonder if the radiologists are, I suppose, in many ways just doing their job.
This has been studied, and we're actually trying to do some studies, or friends of mine trying to do some studies looking at different reporting. So you can do the 1 page or 2 page report with all the degenerative changes at each level listed and documented, or you can have a simple report that says these changes are consistent with age-related changes, full stop. No acute pathology is seen.
Yeah.
Whether you get a different reaction in the patient, whether you get a different reaction in the surgeons, they're obliged to report everything they see.
Yeah.
But there needs to be some difference in how we manage this. Reporting is part of the problem.
Yeah. I know. I think one of Professor Rochelle Bookbinder's PhD students is looking at
yes, she is. Yeah.
at looking at how the effective wording of the radiologist report.
That's who I was referring to, Rochelle.
Right. Yeah. It's astonishing that that kind of thing can have an effect, and you can see it there. It'd be great to do it kind of. I'm just thinking interrupted time series. Following the introduction of. You can see it already. That's probably going to be a significant increase in spinal surgery.
Yeah.
But we could do an interrupted time series one day. That would be really interesting. Pretty stark numbers there, and even the rate of revision surgery as well for all these spinal surgeries is 19%.
That was surprising. In the first study we did, the revision in 24 months was 9%, and in the second study it was 19%. 10 years later.
Yeah, which is both very high. I think we're about to hand over to some questions from the audience. So I might just welcome back Elizabeth, and then we'll get some questions.
So welcome back. We've got questions pouring in thick and fast. I'm not sure if we've got time for them all, but we'll give them a go. So the first one has come through from Ben and saying, given abnormalities are common in people who are symptomatic, should we be referring to them as abnormalities? Wouldn't their absence in asymptomatic people make them normal morphological change? How can we change the language that we use in primary care?
Excellent question. I think we're just kind of discussing that. I suppose there is literally research going into the language in these reports and how we refer to what are effectively a lot of time age-related changes. I'm not sure if you have anything to add to that one, Ian, but I think
No, I think it's important, and I think we need to change it. We've already covered it, but. Whether it be sort of normal age-related changes or some other kind of form of wording, it I think would improve things enormously, because I know patients panic when they say, look at this, so this is I've got all these things, a list of 12 things wrong with my back. And you go, well, no, you've actually got nothing wrong with your back. They're all normal.
Yeah.
Wonderful. Okay. So regarding the low recovery rates post-surgery, if the ongoing symptoms are just pain and those people are still taking opioids, is the pain indicative of ongoing spinal disorder or opioid-induced hyperalgesia?
No, the pain, this is the problem, is that the pain is not due to the spine in the first place, which is why the spine surgery is not effective. The pain, as we all know, is contextual. And in the workers' comp setting, there are lots of drivers, lots of contextual effects, which lead patients to report more pain than they would otherwise. And that's what needs to be treated. And not treated with long-term opioids, because long-term opioids are, I think, contraindicated for such chronic unexplained or chronic sort of non-cancer pain. And they shouldn't be treated with surgery. And in fact, surgery is probably contributing to the problem because surgery can cause more problems. And I think long-term opioids are also contributing to the problems because they can cause their own problems in the long term as well. So the thing is to these people have pain, there's no question, but it's very much contextual. So they need to be treated appropriately. And whether that be a multidisciplinary pain program, including psychology interventions and things like that, that's what they need, because that's what's causing the pain. It's not the darkened disc on their MRI that's actually causing the pain in the first place. So it's not ongoing pain in the spine. It was probably never pain in the spine in the first place.
Awesome. Okay. Interesting how we could potentially change practice around that, and I'll come to that question in a minute. So Michael, there's a question for you. How do you account for the reverse causality that workers who are presenting as most disabled are offered more imaging and more opioids by their treatment teams?
Yeah, I mean, that's absolutely kind of one of the main limitations of that study, in that we can't really say what came first. It's not, it's chicken or the egg, imaging or the longer disability. It's that imaging could have occurred at any point in 2 years from their low back pain onset. So the imaging might have been used down the track, rather than somebody having imaging and then being off work longer. It could have been that they were off work longer and then were imaged to see if anything had occurred. So in a future study, it would be great to look at the time following imaging to a return to work or a partial return to work or something along those lines to look at causality. But you are right, it's an association. They're significantly associated, but the direction of that causality we can't say with this data.
Okie dokie. So one for both of you. What are your thoughts on Sarah's attempt to reduce MRI by requiring concurrent referrals from a specialist if requesting MRI in the first 12 weeks? Is it effective in reducing unnecessary MRI and interventions?
Ian, if you've worked in New South Wales, I'll hand over to you.
I don't know if it's effective because I don't know the data on that. But I think any kind of barrier or hurdle that you put in place is effective. It has been shown to be effective in many other situations. So if you say, not anyone can just get an MRI whenever they want, they need to have this sort of criteria, or they need to have a specialist, or they need to have so many kinds of symptoms, it will decrease the use of MRI. So that should work, but I do not know the results of that particular intervention, so I can't really comment.
I would agree. I haven't seen any evaluation of that intervention yet. That sounds like it would be perfect for an interrupted time series or something along those lines.
Data and publish on it. Thank you.
Yeah, exactly. We'll analyse it and we'll be able to tell you. But there have been similar interventions to that in Washington State, in the US. Their regulator over there worked with, I think, the papers. Gary Franklin is the author of those papers, but they did something similar where they limited imaging in the first 6 weeks of claims for low back pain. But something similar, we just need to evaluate it.
Awesome. Cool. Okay. So regarding What this next one? What are both of your views regarding eminence-based practice versus evidence-based practice in spinal surgery and in compensable scheme? So how do we differentiate between evidence and eminence? Because the surgeon might be rated as a 5-star rating on Google. What are your thoughts on the harm?
Do you want me to take that one?
Yeah.
I've got pretty strong opinions on that one. Yeah, I mean, that's what surgery is. I mean, surgery is a surgeon preference-based practice, and surgeons will tend to do what they're taught. And that's what I did. When I started practice, I was a spine surgeon, and I would fuse workers' comp patients' spines because that's what I was taught to do, and it kind of made sense. And it wasn't until I got into academia that I started looking at the evidence and found out that it just wasn't there, and then stopped doing it. So yes, that's the way surgery is practiced, and it shouldn't be. It's absolutely, you know, this is 2022. There's no way we should be practicing surgery like that. And I think it's the surgeons as a lobby group, doctors as a lobby group in general are incredibly powerful. Insurers do not want to take them on, and they've had their hand bitten trying to take them on. So it's very difficult to shift that, but I think it has to happen. I mean, people have to stand firm. And I strongly believe that we should not be doing surgical procedures that do not have sufficient evidence from comparative studies unless it is part of a comparative study. There's precedent for this. It's been done before in other areas of surgery. In the US, there's famous examples of this, where surgeries became common, and then the payers, like Medicare in the US, said, we're not going to pay for this operation anymore. Well, in fact, we will pay for it, but only if it's part of a study, comparing it to not doing it. And when they've done that, they've found the surgery to be ineffective. And that's what we need to be doing. I think the insurers should get together and say, you want to do a spine fusion on someone with back pain? Great. Let's do it as part of this study we are doing, comparing it to not doing it. And we'll randomize them. Or if it's a decompression, you know, maybe even a placebo-controlled study where patients don't know what they got, which is a much less biased study. That's what we need to do. We shouldn't be doing operations that don't have good evidence. It doesn't make any sense.
Fantastic. So in the last little minute and a bit, I'd like to get both of your ideas around how can we potentially change these behaviours, change the overprescription of opioids, and change the eagerness to put somebody under the knife.
I suppose the first mechanism that always springs to mind, Ian kind of covered it before, is financial mechanisms. Workers' compensation are effectively insurers. The first lever to pull in trying to change delivery of a service is financial. And if some have trialed, not delivering a service unless it's got a certain barrier to it, two practitioners agreeing on a given service, for example, I think that's the most obvious lever. But there are others, education for workers and for healthcare providers as well. And that education has been demonstrated to be effective in the early 2000s. For Victorian workers with Rochelle Bookbinder's campaign with WorkSafe Victoria. Ian?
Wonderful. Thank you. And final words to you, Ian?
So you're asking me what can we do?
Yeah.
Basically. Again, put barriers in the way. Apart from standing firm and saying we're just not going to do it anymore unless it's part of a study, you can do all sorts of things like in Queensland, for example, approvals for spine surgery need to go through a panel. And that panel is senior spine surgeons who have, understand the evidence. And if a young spine surgeon puts in a thing saying, I want to do a 4-level fusion on this patient, they'll look at it and go, no, that's not indicated.
Right.
It won't be approved. It's hard for a claims manager to say, oh, I'm not going to approve this operation that some specialist recommended. That's very difficult to do. But you put it up to a panel of their seniors and they say this shouldn't be done, it won't get done. And again, going back to other studies, second opinion, Rochelle published a study from Brazil where they got spine surgery patients to get a second opinion. And in a huge proportion of cases, the second opinion was that they shouldn't have surgery. And in fact, in a significant proportion of cases, they found that the patients didn't even have a spinal condition. They had something else wrong with them. And these are patients who had spine surgery recommended. So, yeah, putting some kind of check in place. Don't just, a surgeon thinking, yeah, it's a good idea, I think I'll do it, isn't enough.
Right.
Okay, so there's definitely financial incentives, but there's also evidentiary requirements that I think haven't been met. And at least a panel of peers or a second opinion is the least we can do. I think an actual study finding out whether it works or not is what we should do.
Awesome, fantastic. So thank you both so much for what you've shared today. There is some questions that we haven't had time to get towards, so we will aim to get some information back on the platform. And yes, there is a way of watching these videos going forward. So we're going to be back for a wrap up in just a moment. So stay with us as we go through to the next part of the wrap up. So thank you for attending the first Compare Project event for the 2022 Healthy Working Lives seminar series. So we'll be hosting another 5 events over the next couple of months, so watch out and register for those as well. The next event is Thursday, the 31st of March at 12:30 p.m. to 1:15 AEDT. And the topic is, what do we know about secondary psychological conditions in workers' compensation? So make sure you register. This event will be featuring Professor Alex Colley, the Director of the Healthy Working Lives Research Group, and special guest Dr. D.L. Fellman, Consultant Psychiatrist. So we thank you for attending today. We hope that you have had some valuable insights. We've stimulated some discussion along the way. And yes, we'll get back in there and aim to answer more of your questions. Make sure you log into our website, Healthy Working Lives Research Group through Monash University, and you'll be able to access your replays as well. Thank you so much. Have a fantastic day. Thank you again, Ian and Michael, for your presentations today.
If this were to go under, that's the risk I take. I'm froze by this.